Okay. I don't know what Mary covered with you when she talked about oral and nasal airways. I know she had you do a performance evaluation. Were there questions associated with that too? A little bit, okay. So we'll kind of go through some of those aspects. And then the rest of Module A has to deal with nasopharyngeal suctioning, oral suctioning, placement of an endotracheal tube, suctioning of an airway, both closed and open suctioning, obtaining a sample of a tracheal aspirate. That's one of the PEs you'll have. And then trach care. Now in the fall, Mary's going to review some of this material again, but she's going to go deeper. All I'm going to talk about is just your basic tracheostomy tube. She's going to talk about some specialty tracheostomy tubes. I'm going to talk about endotracheal intubation. She's going to talk about other types of endotracheal tubes, endobronchial tubes, for instance, so you can do independent lung ventilation, or use of the glide scope to be able to do endotracheal intubation. So I cover the initial part. She covers the advanced stuff in the fall. And you'll hear me say a lot during this course, and Mary will cover the rest in the fall. It's not that I'm turfing and buffing it to her. It's just that some of the material, I just want to do the basics. Okay? Okay. So there's some stuff out of Egan. You guys are familiar with that text, right? Wonderful. New edition out. I don't know if you've seen it. It's awful slick looking. There's some labs out of Butler. We will have, we're going to skip that very first performance evaluation and just continue on with the rest of them that are there. Okay. So, you guys have seen the clinical practice guidelines. They're basically just directions on how to do these things, why we do them, how we do them, what the problems are associated with them. And there's 3 of them that do pertain to this part of the course that are there. You guys still have those? If not, they're online. You can always go to ARC's website and pull them down. We'll also talk about the ASA's guidelines for difficult airway. I won't, since you have a copy of that, I can't test you on it, but we'll just make mention of it. And there's a website that is there that you can refer back to. So let's talk about the oral airways. And these are the objectives involved. They're pretty much the same for a lot of these as far as terminology and where we're putting them, what the indication, what the contraindications, what the complications are, why would we choose one over the other, and then talk about sizing of the airway, which is probably the most important component. Well, I shouldn't say the most, but it's one of the key parts. Got to know how to size them, got to know how to put them in, and pull them back out again for that matter. Okay. Whew. Okay. Just as a review, some of the functions of the upper airway. Again, this goes back to 10-10-50. Primarily humidify and filter. We also know that there's a function of phonation and smell that is involved, as well as taste. And because the oral pharyngeal cavity is common to both passage of food and air, obviously digestion has a component. 3 paired, 3 unpaired cartilages. Oh my God. I just had a flashback. Should be aware of which are which. And this is out of Egan. 3116 is what it says. I don't know if that's true or not. Yeah, I think that is. But basically, it's an algorithm for being able to manage a cardiac arrest. So how do you handle if they're not breathing or if they're breathing? How do you handle if they don't have a pulse or if they have a pulse? I think it pretty much still follows is the AHA's ACLS guidelines, Advanced Cardiac Life Support, Cardiovascular Life Support, excuse me. So let's talk about the types of airways. Two general types that we have, and three, okay. Two that you'll see clinically, the Guedel and the Berman. Guedel has a hollow center. Berman has an I-beam shaped. So here's an example of the Berman. You can see it's got a central, it doesn't really show really well here, but if you see this right at the very tip here, there's a central part, looks like an I-beam that they would use in construction, kind of a thing. The other type is the Guedel, which has a hollow passageway. Now I will tell you, you'll see people who will attempt to pass a suction catheter either through this internal lumen or along the side. Ain't gonna work. Okay? It's not designed for that. It's designed for airflow to go through. Okay? There's also one that has a Safar that has two mouthpieces so you can blow through one. Yeah, that's gonna happen. In life, I think I've said this before, there's only one thing worse than doing mouth to mouth. Mouth to stoma. Sizing. That was a joke, guys. Measure from either the center of the jaw to the angle of the jaw or the corner of the mouth to the tip of the ear. Okay, both of them will give you exactly the same distance, and they say tip of the ear, I mean tip of the ear lobe itself. So either from the center of the jaw to the angle of the jaw or from the corner of the mouth to the tip of the ear. Physically pick up the airway, measure it, and if it's not the right size, choose another one. Okay? Because there's sizes all the way from a neonate through an adult. And usually the little bag of goodies you have has 4 or 5 different sizes in it. And just kind of making sure we understand some of the terms. The tragus is this little portion of your ear, inner portion, right where the auditory canal begins. Lobe of the ear, helix of the ear. Okay, this is some terminology. So we would place, for instance, a pulse oximeter typically on the lobe of the ear lobe. Okay. So here's what the airway looks like when it's in place. You can see the purpose of it is to pull the tongue out the posterior pharynx. Whether we have a Guedel or a Berman, they both have similar areas that they have a channel, a body, and a flange. The purpose being is that the flange sticks on the outside of the teeth, properly in place. Okay? Is this for view? Yeah. Okay. I won't beleaguer the point, but flange, body, and channel. Opening up the mouth using the cross finger technique, or the scissors technique. It's like snapping your fingers. Put the finger you snap with on the top teeth, put your thumb on the bottom teeth, snap the mouth open. Then I can have the ability to either come from 180 degrees from where the airway will end up, or 90 degrees. Either or is acceptable. I always say the 180 degree turn is probably the more sadistic of the two because you're scraping the roof of the mouth in the process. But if there's some problems where there's pressure necrosis for some reason, an orogastric tube perhaps is starting to cause some erosion of the tongue, some redness and some nasty looking spots, nasopharyngeal gives you another option as far as that is concerned. Patients who can spit the airway out once they regain consciousness, that's when it should be removed. Okay, once they have an intact gag reflex. Okay, manually pull it out or assist them in pulling out. You just pull down towards their chin. The airway will fall out on its own. You want to see a video? You guys have done this, right? Skip it. They should not be used as bite blocks. A lot of ICU nurses will use these devices as a bite block. It causes gagging. Oh, you look like you're gagging, sir. Here, have some propofol. Okay, well, that'll solve the problem, but the better idea is to get something else as a bite block, not using the tube. Okay? Or not using the airway. There's all kinds of devices that are out there. for that purpose. Nasopharyngeal airway, the other one, the NPA, known as a nasal trumpet. These are sized in French sizing, and I'll talk a little bit more about French sizing in a bit. But the same idea, you have an inner channel or a cannula. You have a beveled tip, meaning that it's not flush, it's got an angle to it. And then there's a flange up on top that prevents it from being inhaled into the nasal pharynx. And I have seen that happen, where they kind of got sucked in. It's like, oh my. And if you're really sick, you can go to this site. There's a picture of somebody putting them in each other. If you really want to, you can. You know, save time on it. You did put these in, correct? Yeah, okay. The idea being, again, here is we're going to lift the tongue off the posterior pharynx, whether they're conscious or unconscious. So this is an airway which can be used in a conscious individual that I want to be able to maintain patency for. Say I have somebody whose jaw is wired shut secondary to some mandible repair. They have a lot of secretions in the back of their throat. I need to access and remove them. Rather than ramming a suction catheter down their nose 1,000 times a day, I can put a nasopharyngeal airway in and pass the catheter through that. It's a little bit less traumatic. It's only one trauma instead of 8 traumas. Can also, for both of these, be used to hold the tongue in place so bag valve mask becomes easier. You guys have all done bag valve mask ventilation as part of your checkoff. You know that it can be difficult, especially if you have smaller hands, to manage the airway. We talked about nasotracheal suctioning. And we talked about oral maxillary surgery. Okay, so those are the indications for why we would use a nasal airway over an oral pharyngeal airway. And gee, that might make a nice test question. How do you size it? Well, you lay along the sides of the face and measure from the tip of the nose to the tragus of the ear and add a little bit, or tip of the nose to the meatus of the ear, or tip of the nose to the tip of the earlobe. That's the easiest one to me, is this distance, tip of the nose, tip of the earlobe. Should give you roughly the same distance involved. Also need to take into account the diameter of the airway and seeing how it compares to the size of their nares. Don't really want to cause all kind of dilation and make them have a big nose. So take that into account and go down the sides if you need to. We talked about this before. Should have a water-soluble lubricant. Definitely do not use a petroleum-based lubricant to lubricate it. And basically you want to just hyperextend the neck. Shouldn't need a lot of rotation of the device itself. Sometimes if somebody has some nasal polyps or ends up having a little bit of a deviation of their nasal septum, you may need to rotate a little bit to help facilitate passing it through. I always talk about making a pig nose. So I got to see the floor of the nasal passage much clearer. Okay. They talk about inserting it on the side, with the nair, so the bevel is facing the septum. Did Mary talk about that? Did she mention it? Okay. It really is stupid because you got to rotate these things. So if it's in one nostril, then the other nostril's got to be used next time, and if it's not the one that is appropriate, kind of stuck. So. And when you have it placed, if you ask the patient to stick out their tongue, you should see it sitting back there behind the uvula. There's your pig nose. There is topical anesthetic spray which can be used to facilitate insertion of this and some other stuff. What I really want you to know about that is that they're not benign. Okay, it's a acetylcholine or benzocaine spray. It causes some topical anesthesia. But one of the downsides is that it can cause methemoglobinemia, as well as some other side effects. So it should only be used as a last resort. Cool? And the direction of insertion should be following the floor of the nasal passage. You want to go in a 90-degree angle to the plane of the face. What you don't want to do is go up. Your nasal passage, although your nose runs that way, your nasal passage does not. It actually runs straight down. And although you don't see it that often with the nasal trumpet, there have been case reports of puncturing the cribriform plate and going into the brain. If you're seeing gray stuff come flying out of your tube, you probably have a whole world of hurt. Okay, so here you end up seeing the nasal airway properly fit, and you can see how it's at the base of the tongue there, above the epiglottis, but behind the tongue. Contraindications, obviously, you can get some nasal trauma involved. They don't really make smaller sizes, so for kids, well, that's not entirely true. They do make a pediatric size. I take that back. But you're not going to see them that often known. We talked about that cranial vault intubation, basilar skull fracture with the cribriform plate. And relative contraindication is known bleeding problems. What does relative contraindication mean? Gotta weigh it. Very good. Yeah, I know this complication is here, but I know that if I don't do it, I have this other thing which is worse. In that case, you got to judge between the two. It's a judgment call there. Other complications include nose bleeding. What I really want you to be aware of is having the fact of it touching the epiglottis. Too long of a tube, that's why we want to visually inspect it in the back of the throat. If you're seeing it extend well beyond the uvula, you run the risk of it coming in contact with the epiglottis. That's going to cause a lot of coughing and potentially laryngospasm. Okay. Obviously, there could be some damage in nasal turbinates, that's kind of without saying. And long-term use, because it's in the nasopharynx, it runs the risk of obstructing the eustachian tube and therefore leading to some inner ear and sinus infections. Okay? So they're not benign airways. We try not to use them for long periods of time, but sometimes you have to have an airway there. Maintenance of them, you change them every 24 to 48 hours. And obviously, the ideal is to rotate it or use a new tube in a different, in the other area. Removing it, just again following natural curvature, it'll slide itself back out again. Why do we use water soluble instead of petroleum? You don't want to have any petroleum inhalation, absolutely. Complicated, we talked about. What about an improperly sized oral airway? What if it's too small? It won't hold the tongue up. Right. What if it's too big? It'll induce gagging and potentially block the epiglottis and cause some laryngospasm there also. Yeah, so if I, on a test question, said, okay, I have an elderly non-intubated patient who needs frequent suctioning, which airway would be the ideal for that? Nasopharyngeal. Comatose patient in the ICU? Oral or the nasal, but quite often the oral is easier to put in. Cardiac arrest? Actually, either of them, but an oral is going to be easier to put in, are typically easy to find on your crash cart. So oral would be the idea there. Semi-conscious? Got to be a nasal. Skip one. Requiring manual ventilation? Either of them. Just something to pull the tongue off the posterior pharynx. Helps you manage the airway better. Having something there rather than you holding it and trying to manage it that way. And we'll let those guys go. All right, so there is a lab in there. We're not gonna go through the lab, but you probably will want to review the material, especially the questions at the back. Take a look at page 8 and 9 of the lab manual. Is that the right pages? It should have the PEs there. And again, there should be some oral questions that are associated with that you should be able to answer. What you may want to do at some juncture, get a tab divider and put it between those two sections in the book. It's easier to find for you. All right, let's take a few minutes break. And the need to maintain a patent airway, remove secretions, because the patient has an inability to do so on their own, or despite their efforts at making a cough, there still is residual secretions there. Okay? So 2 indications for it. 2 types, actually 3 types. Oral suctioning, which is basically just cleaning out the oral cavity. You're not going to get into the trachea by suctioning through the mouth. It just, the angle of curvature isn't quite right, and there's too much of a gag reflex associated with it. Nasotracheal suctioning, on the other hand, using a nasal airway and passing through the nasopharynx, you can have access to the tracheal, to the trachea through the laryngeal structures. More commonly, what we'll do is suction through an artificial airway that has been placed. Our PE is with a trach, is that correct? Or nasal trach? Notice I waited until she was drinking something so I could.
You know, I've been doing this a long time.
So how do I know that the need is there? Obviously, you can hear audible secretions, gurgling, audible rhonchi. With or without a stethoscope, sometimes you hear it from the door and you go, oh, this person needs to be suctioned all right. You can end up having fremitus, placing your hands on the chest wall and feeling the rumbling below. If they have an artificial airway in, sometimes you can see the secretions collecting in the tube itself. And obviously, any of those patients who have the weak or ineffective cough are ones that need to have that process done. Clinically, they're going to look like they're having struggling breathing, being tachypnic, tachycardic, and certainly their SpO2 level will be reduced. So clinical signs that you would end up needing to be suctioned. What kind of equipment do we need? Well, obviously you need some kind of a vacuum source that has a calibrated regulator that's adjustable as far as the amount of suction pressure that you're going to utilize. You'll need some sort of collection container and tubing that leads to that. So you don't want it lying on the floor. You want it someplace. And we're going to use a sterile suction kit that has a catheter of appropriate diameter, pair of gloves, and sterile water and cup. Do they have 2 gloves in there or 1? I don't remember. I think most of them have 1.
It's the new setup we're using.
Okay. Usually it's 2, but sometimes there's only 1. Either way, one of those hands will be designated as a sterile hand. And we'll go through this. You're going to need a little bit of sterile, normal saline, possibly to irrigate the endotracheal tube. A water-based lubricant can be used. We talked about a local anesthetic being a possibility, but if you're suctioning through the nasotracheal tube, the NPA, you may not need to have that anesthetic mechanism there. Should always have resuscitation equipment nearby, as well as some other monitoring device like EKG and certainly an oxygen delivery device. And Mary talked about standard precautions previously, and recognizing that patients that you're suctioning always have the potential to generate a cough at just the right moment and have projectile. So I always say stand to the side, don't stand in front. Here's an example of some of the regulators that you'll end up having. I have a control knob here which allows me to alter the vacuum pressure. My suction collection chambers you can see with my attached tubing, the opposite end of which you're going to connect to your, one end will be connected to the collection chamber, one end will be connected to your suction catheter itself. So there's our regulator that's going to control the amount of pressure involved, our collection chambers, and our connecting hose. Okay. So here's an example of an oral suction tip, also known as a Yankauer suction. And basically it's used to suction the back of the oral pharynx. It's not going to do a whole lot as far as moving beyond that. In fact, you'll induce a gag reflex if you're using a patient that has any level of consciousness at all. But in this case, you're able to basically clear out the back of the throat. So one of the things that, especially with an oral endotracheal tube in place, you have a lot of oral secretions and you need to clear those out and maintain good oral hygiene. We're going to use in the lab today is the more standard flexible suction catheter, where you end up having a thumb port that, when occluded, allows for vacuum to be applied. When your thumb is not on that, the vacuum is pulling gas through that thumb port, therefore the patient is not having vacuum applied to their airway. Make sense? Okay. We'll also talk about a closed suction system. Patients who are mechanically ventilated with an endotracheal tube or tracheostomy tube in place, we really don't want to have to use a suction kit each and every time you suction that patient. Rather, we're going to use a suction catheter that's inside a plastic sheath, and you slide the catheter forward by manipulating it through that sheath. Okay? So it's basically a sterile system on the inside. Outside is dirty, but we're not coming in contact with that. Okay? Both catheter types have they have a beveled tip so that it doesn't come in contact as easily with the tracheal wall. Because what you don't want to do is have that catheter pulling the tracheal tissue, causing localized tissue damage. And that's the purpose of the Murphy eyes. Those are called Murphy eyes. The little holes along the side that if I was to have this up against the tracheal wall, there wouldn't be vacuum applied at that point. Rather, the vacuum would allow gas to be entering in through the opposite sides. Okay? So it's kind of a safety feature built into it. There are some specialty catheters Mary will cover in the fall, one of which is called the Coude, which allows us, it has a little bit of a bend in it that allows or facilitates the entering of the left mainstem bronchus as opposed to the right mainstem. There's all kind of designs there, all kind of go along the same thing, trying to reduce the amount of traumatic damage that can be done to the tracheal airway itself. We will have a situation where we'll use a Lucan's sputum trap, which is a collecting chamber to get a sample. So I'm putting a patient on a mechanical ventilator. We've just intubated them. That first time we suction, we'll typically do a sputum specimen to get whatever the patient might have already been colonized with, to be able to identify it. This has to be spliced in between my vacuum tube, my collection tubing, and my suction catheter. Once I do my aspiration, then I need to remove that sampling chamber, reattach the suction catheter to the collection tubing, and probably do another pass. Oh, and by the way, this is all done in a sterile fashion. It's almost like you need a third hand. But we'll show you tricks on how to end up doing this. Okay, that's probably the hardest part of this PE, is doing the collecting tube collection mechanism in addition to the suctioning itself. There is a special type that you should be aware of just for explanation purposes, and it's called a DeLee suction, DE, and basically this catheter is placed into the infant's airway, and the vacuum source that is utilized is you. You suck on this end and it draws the fluid in. Not as commonly done. There you can use, and people typically will end up using vacuum sources instead of you being the vacuum source, but that's the way this was initially designed, to have manual aspiration. Yuck. There are on some tubes, to be able to know how deep you are, there are markings on it. Well, we talked about the various types that also had a little Murphy eye on the side. Okay? And there's our thumb port that we put our thumb over. So again, oral suctioning, we're just going to use that Yanker catheter with some vacuum, collection tubing, and personal equipment. And that's basically the vacuum source, obviously, just creating negative pressure back here, drawing whatever's at the distal end back into the collection chamber. And there's our Yankar suction. There's a thumb port on some of them that will allow you to control the flow, but we're hooking it up to our vacuum source, and the opposite tip then is placed into the oral pharynx to be able to suction it out. How many people have seen one of these before? Most of you? Cool. Okay. So we'll hold off on that. When we go into the lab, I'll go ahead and give you a demonstration on that, but this is basically what we want you to do. Wash hands, put on non-sterile gloves because it doesn't have to be a sterile procedure. We're going to have some mechanism to fill a basin with some sterile water or saline. And obviously whenever you open up a sterile bottle of saline or sterile bottle of water, you want to date the bottle so that we know how long it's been there and dispose of it appropriately. Attach my Yanker suction. Verify that it's functioning by putting it into that water source. That's what you tell if the system's got a leak in it or not. And then we're going to need to set our appropriate level of vacuum. Okay. So what we're going to do is we're going to set that vacuum level while occluding the tubing. So the connecting tubing that we're hooked up to the suction catheter, we occlude the end of that and we verify where that suction pressure is at. And you should know, put a star by this. Well, it's already got a star by it, but make sure you know by it. 100 to 120 for adult, 80 to 100 for a child, 60 to 80 for an infant. Okay. Some of them are in inches of mercury just to make life miserable, and there's the values there, 10 to 15 inches of mercury. That's some of the portable units we'll end up having. Okay. So once I have the proper level of vacuum applied, I have my suction catheter attached. I've verified its function by putting the tip of the Yanker into some water. I talk to my patient and inform them what I'm going to do. I'm going to clear out the back of your throat. You may feel a little bit uncomfortable. And we're going to go ahead and apply suction while we pass it through the patient's mouth to the back of the throat. Got to be careful not to go too deep because you'll induce a gag reflex. You can have you guys have all been to the dentist, right? Put your mouth around the thing and clear out your mouth. Same idea. Then rinse it and repeat as necessary. All through this, we're monitoring the patient for respiratory distress or hypoxemia. Okay. Once it's done, some of the systems have, some of them are really slick. They actually have an outer sheath that slides open and closes over it so that it's protected. What do we do nowadays?
We keep the original packaging, paper packaging, and reinsert that in paper packaging, and take it to the bed rail, or take it to the vent, and change it on daily.
Yeah. I can't tell you how many times I've walked into the patient's room and the suction catheter is lying on the floor. It's like, get a new one. Get a new one. Yeah. Change them daily. Or if they're on the floor. Once you're done turning off the vacuum, we'll first of all make it quieter in the room, and then, and again, this is potential for having infectious materials, so you may need red biohazard bag and document. Okay. Actually, 1960 probably isn't a truthful statement. But here's an example of a suction kit. 2 gloves, a little canister, and a suction catheter. It's inside of a paper, that's what I'm looking for. Paper bag, yeah. That when you unfold it, it now becomes a sterile field. So we'll show you how to do this in an aseptic method. Okay. So, again, my disposable sterile suction kit. The rest of the stuff is pretty much the same. But my disposable sterile suction kit has a suction catheter that is measured in French sizing, and I'll talk about that in a sec. Certain length, so you're looking at just under 2 feet. Ah, it seems awful long. I don't think it's quite that long. And again, it's a beveled tip with the holes on the side, a thumb port. They're all clear, and it's a sterile. So here we end up having our connector for the vacuum, our thumb control, and the tip on the very end that goes into the patient. And that's the sterile kit we talked about. And notice that it is sterile. Okay. So we need to figure out what size tip is involved. And these are, again, multiple types. We're going to not concern ourselves with the different brand names or anything like that. Just recognize that they all have that Murphy ion on the end to protect them. Who don't we do nasotracheal suctioning on? Obviously, epiglottitis and croup are strict contraindications. Absolute contraindications, absolutely. Some of the other contraindications, occluded nasal passage, bleeding disorders are a relative contraindication. Somebody who has hyperreactive airways need to assess the risk versus the reward of being able to do it. Same is true for the rest of them. Complications that can occur, well, same thing as if you we talked about the nasotracheal or nasopharyngeal airway, excuse me. You're going to have those same kind of complications associated with it. Because I'm applying vacuum, I run the risk of also inducing hypoxemia and tissue hypoxia. Because of that, I also run the risk of cardiac dysrhythmias. Whenever the oxygen level is depleted, the myocardium can become irritable, and I can end up developing at the very least, a sinus attack, but certainly as significant as ventricular tachycardia and ventricular ectopy. Oh, and by the way, your patient can die, so can't go into cardiac arrest or respiratory arrest. And you can see some of the other complications. Why do I have atelectasis twice? Just notice that. That's pretty silly. Okay. Patients with intracranial hemorrhage or intracranial pressure are again a relative contraindication you need to be observant of. You don't want to cause intracranial pressure to increase further and cause hemorrhaging to happen. And we'll show a demonstration of that. But what we're going to do is wash our hands, put on our personal protection, put them in a position where they can easily access into the trachea, what is called the sniffing position. You guys know what that is, right? How do you sniff something? You lean your head forward and extend your neck. Literally, that's what you end up doing with the patient. Pre-oxygenate them, have them take some deep breaths if they're not on oxygen therapy. If they're on oxygen therapy, you can certainly turn the oxygen up to pre-oxygenate them. Verify the proper suction pressure, and by the way, did I tell you it's 100 to 120 for an adult, 80 to 100 for a child, and 60 to 80 for an infant? Okay, if I haven't, I just told you again now. Okay. Now we need to go ahead and get our supplies. We're going to open our sterile water, keeping the cap in a sterile fashion. What does that mean? I don't unscrew the cap and put it open end down. I put it closed end down. So I'm maintaining sterility. I open water-soluble lubricant if I need to. Again, it's going to be in a sterile fashion. I open my kit, keeping it sterile. Keeping it sterile means I don't reach over the kit. I reach from the sides and pull it away from me. Once I have that open, it now is sterile on the inside. I need to maintain that sterility. Put on my sterile gloves. Okay. One of the gloves are placed in there so they're folded over. Putting one on and then lifting in the cuff, I can pull the other one on and get them both on. One hand now has to be designated as sterile. You'll figure out which one it is. But once that one is sterile, it cannot be used to touch anything else. Okay. I also have in there my sterile, there might be a sterile drape. not always. I have my basin. The basin is in the sterile field. Right now, both hands are sterile, so it doesn't matter which one I use. I reach in and I grab the basin. I set it down. Now I got to add some, I take the catheter, and usually use your dominant hand, whichever one that is. The catheter will be inside a little plastic or a paper sleeve, slid in there. You're going to go ahead and reach in and grab it. At this point in time, both hands are still sterile, so it's not an issue. Throw my thing away. Now I need to fill the basin. Now I need to make sure that whichever hand doesn't have the suction catheter, and what I always do with a suction catheter is I wrap it around my hand so I can hold it in my fist. Other hand now becomes non-sterile. I grab the water bottle, I pour water in a sterile fashion into my little basin there. I grab the suction tubing and attach it to my suction catheter. I can now open it up, holding on to the very tip. I can verify suction function by taking the tip into the sterile basin in a sterile fashion and applying vacuum. Okay, it works fine. Now I'm going to go ahead and be able to lubricate the catheter. Usually what we'll do is take that lubricant and place it in the sterile field. I can just rub it in there and being able to get some tip of it on there. And then, again, monitoring my patient for respiratory distress in the ways that Mary taught you last semester. Hold the catheter near the tip. Again, you have better control over where that tip goes the closer your hand is to that tip. Go ahead and insert the catheter into the nasopharynx through the nasopharyngeal tube, or in the tracheal tube as the case may be. And we're going to insert it having the patient, if it's nasopharyngeal area, you can facilitate getting into the trachea by having them stick their tongue out. Okay. I'm inserting it without vacuum. Okay. The catheter moves far easier if it's not applying vacuum at the time. Think about it logically. Okay. You can pass it through. If the patient gags or vomits, obviously we're going to stop the procedure. But basically, if they stick out their tongue, we're increasing the chances, especially in the sniffing position, of entering into the trachea. Once that catheter passes through the vocal cords, what are they going to do? They're going to, well, not gag even, they're going to cough. Cool, that's what we want. Cough moves secretions more centrally. Applying vacuum, then I can go ahead and be able to get some secretions removed. So again, here's the head in a non-sniffing position. Here's the head in a sniffing position. I'll show you that in the lab when we go. If you meet an obstruction, don't force it. Rotate the catheter. Once we're into the trachea again, with them having their tongue sticking out, we can end up applying vacuum. Once you start seeing the cough, then we can apply vacuum and intermittently apply vacuum on the way out. Whole thing taking no more than 10 seconds. Once we're done, remove the catheter, rinse it, and then once you're finally done, go ahead and suction the mouth after you're complete with attempting to get into the trachea. And then after procedure, post-oxygenate them and make sure that their heart rate is returned to normal and the respiratory rate is returned to where they were previously. And that last bullet point makes logical sense. Get rid of the equipment, turn off the suction, reevaluate, blah, 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 blah. All the things you would expect it to do. Okay? Suction catheters are in French sizing. We measure in the tracheal tube size in millimeters of mercury. Millimeters of internal diameter. What you want is a suction catheter that does not occupy anything more than 2/3 the diameter, no more than a half of the diameter of the airway. So if my airway is 4 millimeters in diameter, I want to have that, let me rephrase that. A rough rule of thumb is to go ahead and, it is two-thirds, multiply that diameter by 2, and that'll tell you the French size to use. Now there's not an 8 French catheter. There's 6 and 10. I don't think there's an 8, is there? Okay, if there was an 8, then you would want to use the next smallest because you want it smaller than that size. So with a 6, what would you use? 6 times 2 is 12. So we're going to use a 10. I gotcha. 7.5. 7.5 is 15. Next smallest size is 14. They're always in even numbered French sizes.
So you go up one?
You go down one. So if I have a 10 millimeter tube inner diameter, 10 times 2 is 20. Size smaller would be an 18. Okay, so page 19 in your lab manual has this lab as far as what we're going to have you guys do. Okay, so let's take a break and meet up in the lab in about 2 or 3 minutes.
Still here? It's over.
I would bring your lab with you, yes. You probably don't need the whole binder, but at least bring the lab.
Okay, you just have to nod for this. So let's just say my number came out to be 17, and write down to 15, but it's only even size.
There's
Yes.
14.
I just used 14. But if
Well, if it's a 17, you do 16.
Oh, right, okay. Okay.
So if you had an 8.5 inner diameter tube, that'd be 17.
Just that.
You need that.
Okay.
You need that. So it looks like it's 19 through 23 is the lab.
It's page 19 to the bottom, and then it goes through 23. They didn't make a mistake, it was me. And she was very good at it. And before I found no, she's like, I have to write this. Right, okay. She said, no, she didn't trust it, then she called me back after I called. She already lit it. I'm just saying, she never looked at her. I didn't know what was in it. I think something are very Mary's home and she says on lunch that there's just a month short. So, you usually let me know if there's like a noise?
I'll let you know. I don't know if we have the box.
No, and what's that? Did they give you an email or anything, or you could ask for email or anything?
Oh, I don't know. Honestly, I don't remember.
I was wondering about it.
But I'll let you know.
Good, how are you? I was late, I'm Brian, and I was from working now. Never looked up.
Right.
I think no, she gave out LEDs for birthday gifts.